All right, moving on to peripheral nervous system. Right, so we just finished up central nervous system, which is brain and spinal cord. We looked at how the nerves come off. We looked at the structures, some dysfunctions. And now we're going to move into peripheral nervous system. So peripheral nervous system, what we're going to focus on in this lecture is cranial nerves and spinal nerves. Okay, your autonomic nervous system is in the periphery as well. Okay, just as a sidebar. But we're going to focus on cranial nerves and your spinal nerves here. Okay, so we're going to look at the sensory receptors. We talked about sensory as it goes into the back of the cord. We're going to look at where the actual receptors are and what they are. Okay, we're going to look at some peripheral nerves and their associated ganglia. And what is a ganglia again? Collection of cell bodies. We're going to look at motor endings. So as the nerves go out to the muscles, we've actually looked at this. When we looked at the synapse, right, we looked at how a nerve talks to a skeletal muscle. That's basically your motor ending. Okay, you pop some acetylcholine into that synaptic cleft and you make the muscle function. Okay, so that's actually pretty easy. So we're going to look at all these peripheral structures. Okay, let's look at the nerve structure itself. So if we were to actually take my radial nerve, pull it out, cut it in half, and look down inside of it, it's actually made up, the nerve itself, of dozens or hundreds of axons. But as you can imagine, those axons are very thin. You need to have them grouped together so they don't get mixed up. So this teeny tiny structure here is an axon. Okay? That is surrounded by myelin, and you have dozens or hundreds of, I don't know how many, grouped here. And they're grouped in what are called fascicles. There are several fascicles within the nerve itself. Okay, you can see there's blood supply running through those fascicles too. So here's the axon with the myelin sheath. Each axon and myelin sheath is surrounded by connective tissue. I don't know if you could read this. Endoneurium. Can you read that in your notes? Is it clear? I don't know. No. Endoneurium. Do you want me to spell it for you? Or do I have it in the notes? Do I have it in the notes?
It's there, it's just small.
Okay.
Yeah, it's hard to see the picture, but the words are there.
Yeah.
Endoneurium. 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 The fascicles are surrounded by a small connective tissue sheath called the perineurium. P-E-R-I. The whole nerve is surrounded by the epineurium. And the epineurium actually goes right up and molds into your dura mater on your spinal cord, kind of making one continuous sheath around the central as well as those peripheral nerves. It's just around the peripheral nerves. It's known as epineurium. Okay. Does that make sense? Okay. Just how they're grouped together so they don't get confused and mixed up. Now, we have different receptors all over the body, and there are small structures that lie in the skin or around the organs or around joints that have specific functions. In general, the way they are structured is they are either unencapsulated or encapsulated. That simply means the encapsulated have a little connective tissue sheath around them. Okay, a lot of them are round, so there'll be a little round receptor with a connective tissue around them. The free nerve endings look like the ends of a nerve, like a tree. Okay? Are you with me? And I always remembered the unencapsulated because they quite often deal with things that are either painful or could be painful. Okay, so unencapsulated deal with receptors that sense pain, which is nociception, or thermoreceptors, which would deal with what?
Temperature.
Temperature. And why do I say that thermoreceptors have the potential to be painful?
Like you can feel the heat coming off of something.
Right. Right. So thermoreceptors and nociceptors are unencapsulated so they can quickly sense either painful stimulus or if the temperature is getting too hot or too cold. They'll get stimulated pretty easily. And that's something we're delicate creatures. We need to have that response ready to go at all times, right? Okay, does that make sense? Now, encapsulated will include Meissner and Pacinian corpuscles, both sense pressure. These two sense pressure. Muscle spindles sense movement of muscles. Golgi tendon organs sense the movement of tendons. Their length, where we are in space, okay? And then we have mechanoreceptors. I don't know why I put mostly. You can cross the mostly off. Mechanoreceptors that deal with something called proprioception. And what proprioception is, guys, is if I'm driving into work and I've left my bubble gum in my back seat and I want to get it, I know I shouldn't, but what do? Right? Oh, there it is. Proprioceptors allow you to reach back and know where you are in space without seeing it. Okay, they're receptors in joints that allow us to know where we are in space without seeing. Okay, does that make sense? Okay, so receptors. We have capsulated, we have unencapsulated. Unencapsulated will be the ones that sense temperature and pain. Encapsulated are going to sense pressure, where we are in space, right? Muscle movement, tendon movement, joint movement. Okay. So there's two major groupings that we're going to talk about now with the peripheral nerves. There are spinal nerves and there are cranial nerves. Why do we call these cranial nerves? They come out of the cranium. Very good. What do we call these spinal nerves? Come out of the spine. Okay? So with spinal nerves, there's 31 pairs. We're going to go over all the pairs in a little bit. They go down the whole spine, from cervical down to L1. Okay? Well, further than that, I should say. C1. It's got the dorsal and the ventral joining to form the mixed spinal nerve. Do you understand what I'm saying by that? I've gone over that a couple of times. If you're looking at the cross section of the spinal cord, you've got the spinal nerve rootlets on the dorsal aspect coming out. Those are sensory, motor from the front, joined together to form the mixed spinal nerve. We'll go over that in a little bit. I have another picture of that. Okay? Cranial nerves are their entirely own animal. Okay? I laugh because you'll learn to love and hate them. Okay? There are 12 pairs that come out of either the base of the brain or the brain stem or the top of the spinal cord. They go to the head, neck, and there's actually one that will go to the chest and the stomach. Okay? They're clinically important. If somebody has a head trauma, quite often you will screen their cranial nerves to make sure that they aren't having the beginning of pressure in their brain. Okay? So, sensory receptors are going to respond to changes in the environment. That makes sense. The activation is going to be graded potentials, which will create an action potential, which will bring that sensation in. Okay? I think these are a lot of big words for a lot of what we've described already, so don't worry about this. But I took some of the notes from the book, and sometimes their verbosity is something right. Okay? So, classification by stimulus type. So these are like overall groupings. I already gave you some specific examples with the thermoreceptors, the nociceptors, Meissner's corpuscles. Those are specific examples. These are like overall groupings. So mechanoreceptors respond to touch, pressure, vibration, stretch, and itch. Thermo is going to be temperature. Photo is going to be vision. I'm going through this quickly because I think it makes sense, right? Okay. Chemo is going to be smell and taste. Okay. Nociceptors will be pain, which we spoke about. And thermoreceptors can actually embark into nociception, right? Okay. Does this all make sense? So that's kind of like an overall description. I should put that before the other screen. Okay, don't let this blow your mind. How many nerves brings motor from the brain to the body? We just talked about it. 2. You have an upper motor neuron which goes from the brain to the front of the cord. A lower motor neuron which goes from the front of the cord to the body. Okay, so motor has 2. Why? Maybe a physiologist who studies this would know. I don't. That's just the way it is. Okay, for our purposes. Sensory has 3. Why? Some of them have 2. Most of them have 3. Okay, we're going to go with 3 for our purposes. Why? That's just the way it is. Are you with me? So don't let this blow your mind. We're going to keep it really simple. The first one comes from any one of those sensory receptors, whatever it may be, if we're sensing, pressure, temperature, pain, whatever. Okay? The first one will bring that information up the back part of the spinal cord. Are you with me? Oh, I'm sorry. Actually, it'll go into, hold on just a second here. What? Goes. Okay, let's go with this instead. I just glimpsed at that picture quickly. Okay, so sensory information is going to come from the body to the dorsal root ganglion. Remember we looked at that dorsal root ganglion that's at the back. Let me show you a picture. Hold on a second. And I'm jumping ahead of the notes a little bit. Okay. Here's your dorsal. We're looking at the spinal column. Here's the vertebra. Here's the spinal cord. Are you with me? Sensory information comes in. Here's your dorsal root ganglion. Do you remember that now? Okay. Your first nerve, okay, will send information to the second nerve here. Okay, are you with me? This will send to the second nerve, which goes to the thalamus. Okay, so body to dorsal root ganglion to thalamus. Are you with me? And then thalamus to brain. Did I lose you there? Okay, body to dorsal root ganglion to thalamus, thalamus to brain. So I don't like this picture because it's bypassing the dorsal root ganglion. I know you guys are like, what is she talking about? But trust me on this one. Don't worry about that picture, okay? We're gonna go with this. So first order neurons. So 3 nerves in the sensory pathway. And you could even write this down if it makes more sense. The first one goes from the body to the dorsal root ganglion. The second goes from dorsal root ganglion to thalamus. Could also go to the cerebellum. And then thalamus to the brain. Let's just stick with thalamus, okay? Right, does that make sense? Okay. So 3 nerves. 1, 2, 3. Okay. All right, so let me back up a little bit here. Okay, so this picture you can just cross off. Anyway, okay, so adaptation of sensory receptors. So you got it this morning, you drove into school, you got dressed, you brushed your hair, you put in your contacts, you put your hat on, you put your scarf on, right? You ate your meal, you're drinking your coffee. Do you think about every step that you've taken? Do you think about the chair you're sitting in? Do you know what color the walls are? Do you know what color the rug is? Okay, no. Can you process? It's like me with my kids. I love my kids, but this morning I need like at least a cup of coffee before I can like think. And my son got like I can't take that all in, right? We can't take every inch of information in all the time. You have to adapt. That's why you don't feel your clothes all day. That's why you don't sense that you're sitting all day. Your brain can only process so much. It adapts. It'll start to shut down unnecessary information coming in. Okay, so those receptors just become less responsive. Those potentials or action potentials will not be perpetuated all the time. Okay, it can only take so much. Don't talk to me until I've had my second cup of coffee. Okay, these are those 3 steps which we spoke about. Okay. Oh my gosh, once again, this is your book going crazy for such a simple topic. Cross this off, and this is what I want you to put. Most nerves are mixed. That's what all this slide is saying. Okay? Most nerves are mixed. Some are just sensory. Some are just motor. I'll tell you which ones are which when we get there. Done. Okay? If you really want to read through this, that's exactly what this slide says. Okay? Ganglia. I should have gone through these notes before I lectured about it. Sorry about that. All right. So dorsal root ganglion we talked about. It's a collection of nerve cell bodies associated with the nerves. So dorsal root ganglion, and we've looked at it, is in the back of that whole spinal cord complex that we've looked at, right? That'll be collections of cell bodies for sensory nerves. Does that make sense? We are also going to look at autonomic ganglia, okay? So autonomic ganglia are going to be collections of cell bodies in the autonomic nervous system. We're going to look at sympathetic and parasympathetic. We'll look at them case by case. I just want you to understand that they'll be in different areas, okay? All right, regeneration of nerve fibers. Before we even look at this, I'm sorry, was I going too fast? You guys need more? You got it? Okay.
Just for the autonomic ganglia, that would be in the front, or it would be motor, so it would be in the front.
No, it's going to be completely different. There are different locations.
Okay.
They're paraspinal and they're also next to the organs, completely different. We're going to look at it. Don't worry about it.
Sorry.
No, don't worry about it. All right, so regeneration of nerve fibers. Where, well, will we create new nerve fibers? No. Where can we regenerate them?
Periphery.
Yes, in the periphery. So on this slide, we're talking about the peripheral nervous system. Okay? As long as the cell body itself is still intact or the ganglia is intact, you can regenerate the axon in the peripheral nervous system. Are you with me? Okay. The ends of the nerve need to be close. I already told you the story. Did I tell you guys a story about my cousin and she was cutting fruit and she cut her finger and she let it go because she had hockey camp? Well, now she has permanent sensory loss in her finger from that. Because she's like, I'll take care of it later. I'm like, no, you have like a week. You gotta 2 at most. Because you gotta have the ends of the nerve approximated. And once it's approximated, if it has a good surrounding blood supply, Schwann cells will create a myelin tube, and then you'll see little projections come from that nerve, and it'll mend itself back together, okay? So it has to be peripheral because it has to have the Schwann cells, and the ends have to be approximated or close to each other, okay, for it to regenerate. Okay? So, and what it means by soma of the damaged nerve, it means the cell body. Okay, it means the cell body itself. Macrophages will come in and remove the debris. Those Schwann cells will form a myelin tube. It'll secrete growth factors. It'll allow it to repair, and then the axons will regenerate. Oligodendrocytes will not. It has growth inhibiting proteins that actually inhibit it from regenerating. Oops, somebody messed up there. Somebody didn't get the note, unfortunately. So what they're trying to do is they're trying to take Schwann cells and put them in there, or stem cells. All right. Any questions, guys? Okay. So, cranial nerves. Let me see how far I am into the notes. Okay. Cranial nerves. The cranial nerves come out of the cranium, right? Brainstem, top of the spinal cord. There are 12 of them. They are every student's nightmare, so I try to give you mnemonics to learn them. Okay? There are dirty mnemonics out there. I don't use them, okay? Just so we're clear, I've slightly modified them. You should also know the Roman numerals. If you don't, do they teach this to you guys anymore?
I think so. Really? I know them
Roman
somehow.
numerals?
Oh, good. Okay, so 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. If you're going to go into neurology, you got to know the Roman numerals. Okay? So, the cranial nerves are the 12 pairs. So there will be one for each side of the body. One to the right, one to the left. Okay? They're identified by the Roman numerals. Some are sensory, some are motor, some are mixed. This is where we get the sensory and motor. Okay? This is the mnemonic they give you. If that sticks with you, great. Okay? Here's what they look like. And I'm going to go through the mnemonic in just a second. The way that I study them by location, and we'll be doing this in lab, is I go by number from front to back. I mean, you could go by name if it works for you. It's just always easiest for me to memorize the names, memorize the mnemonics. You brain dump on the test, write it all down, and then I do 1 through 12 on the base of the brain. So you'll need to know these locations. I'm not going to go through them now because first of all, they're self-explanatory. Second of all, we're going to do them in lab. Okay? So you'll need to know the locations of them as they come out of the brain. What you're seeing with cranial nerves are the axons forming the nerves. The cell bodies are either in the brain or the brainstem, and then they send their axons out. Okay? Does that make sense? Okay. So here they are. Now, we have this little chart. Okay. So here's the names: olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, vestibular, cochlear, glossopharyngeal, vagus, accessory, hypoglossal. Okay, you'll need to learn those. In order to remember them, the first letter of every one, ooh, ooh, this is a clean one, to, touch, and feel, very good. Vegetables and honey. Nothing dirty in this class. Okay? Olfactory, ooh. Optic, got it, ooh. Ocular motor, ooh. Got it? Okay? If you want to do the trusty truck, some people like that one that's previously in the notes. What you want to make up your own, I don't care. Do whatever you want to do to remember these. Okay? I still use this mnemonic, right? Okay. Now, how do we know if it's sensory, motor, or both? Another mnemonic. Some say money matters, but my brother says big business means more. Olfactory, sensory, optic, sensory, etc. Okay? Sensory, motor, both. Okay? No?
I just can't read. What's under big?
Oh, some, 1, some, 2, say, 3, money, 4, matters, 5, but, 6, my, 7, we're doing this aloud too, brother, 8, says, 9, big, 10, business, 11, means, since we're doing it this way, 12, more. All right. And then here is the general function. We're going to go over these more in lab. Okay. Olfactory is smell, optic is vision. Ocular motor, trochlear, and abducens. If you want to lump those three together and put eye movement, eye movement, eye movement, that's their primary function. Oh, I'm sorry, and that would be motor. Just function in general I'm talking about. I'm not talking about sensory, motor, etc. Okay? Trigeminal is going to be sensory to the face and chewing. Do I have this in the notes somewhere? Am I getting ahead of myself? Hold on. You don't. Okay, that's okay. We'll go through it now. Do I have it back here? No. Okay. So, olfactory, smell, optic, vision. Oculomotor, trochlear, and abducens are eye movement. Trigeminal, sensory of the face, muscles to chewing, also known as mastication. Facial, does anybody need me to repeat any of those? Facial is movement of the face, other than chewing. Taste to the front of the tongue. Facial allows you to make faces, motor to the face, taste to the front of the tongue. Does anybody need me to repeat any of those? Vestibular cochlear deals with hearing and balance. Oh, and it's right here. Okay. Glossopharyngeal is taste, but it also raises the soft palate. When people say ah, okay, vagus and glossopharyngeal help to raise the soft palate. Do we have all those? I know I'm giving you a lot. I'm going off-roading today. Okay. So vagus and glossopharyngeal raise the soft palate, but it's very important for you guys to know Vagus's nickname is vagabond. And what do vagabonds do? I don't know, is that like an antiquated term? Am I dating myself again? They
I've
wander.
never heard that.
You've never heard it? Shut up. No, I'm just kidding. I'm kidding. Okay. It means wanderer, because the vagus is the only one that goes beyond the neck, and it actually gives you all the parasympathetic to the chest and abdomen. It's amazing to me. Okay? So vagus, parasympathetic to the chest and the abdomen. And we'll go over that in autonomic nervous system too. Okay. Accessory raises the shoulders. And it also causes this muscle to contract, your SCM, which just know raise the shoulders for now. And hypoglossal sticks out your tongue, creates tongue movement. Okay? Those are good general descriptions of cranial nerves. When you look in your book, it's extensive. If you want to take bread and butter clinical stuff, know what I just told you. Because that's how you'll test them. Okay?
What's accessory then?
Raises the shoulders. Upper trapezius. Okay? All right, so for cranial nerves, you'll need to know Roman number, name, right, which I gave you the mnemonic for, sensory motor or both, which I gave you the mnemonic for, and a basic function. You feel okay with that? Okay. Okay. All right, spinal nerves. 31 pairs of mixed spinal nerves named according to their point of issue from the spinal cord. It's just where they come out of the spinal cord. Oddly enough, what's interesting about 8 cervical? 8 cervical spinal nerves. How many vertebrae are there in the cervical spine? 7. Okay, 7. What happens with, and you notice, do you know how many are in the thoracic spine vertebra? You guys don't know yet. All right, that's okay. There's 1 extra cervical nerve rootlet. Okay? It's because the numbering starts above C1 and ends below C7. And then after that, they're numbered underneath the vertebra from which they come out of. Okay? So 8 cervical, 12 thoracic, which matches the 12 thoracic vertebra, 5 lumbar, which matches the 5 lumbar vertebra, and then we have 5 sacral and 1 coccygeal. Okay. They come out from those regions, they're mixed spinal nerves, and then they will go out into the body. Okay. Does that make sense? Okay, so just a refresher, here's our motor, here's our sensory, here's the dorsal root ganglion. They form a mixed spinal nerve. Does this look familiar? And immediately they branch into a dorsal and a ventral root. Ventral just means it's going to go to the front part of the body. Dorsal goes to around the spinal column. Okay? We also give, excuse me, nerves out to what's called a sympathetic trunk. The sympathetic trunk will look at an autonomic nervous system. It's a series of nerves that run right next to the spinal column that have sympathetic fibers in them. And the sympathetic fibers create our flight and fight responses. So we'll get into that in the future. I just want to show you the location of it. But for now, we're going to see how that mixed spinal nerve splits into a ventral and a dorsal portion. Are you with me? Okay. So this is a picture of those nerves coming out, C1 through C8, T1, T12, etc. Now, what will happen with some of these nerve rootlets, actually most of them except for the mid-thoracic, is they'll come together and combine to create what's called a plexus. There's a cervical plexus, there's a brachial plexus. I combine it as lumbosacral plexus. Your body puts it as lumbar and sacral. And what a plexus is it takes several of those nerve roots and mixes them up. Instead of having one muscle have the nerve from one nerve root, we get a whole bunch crossing over. Why would that be beneficial for us? What if I had C2 was the only nerve that went to my biceps, and I damaged C2 by having a huge herniation? Would my biceps work anymore? No. Instead, we mix a couple of nerve roots, I think it's 3, 4, 5, that goes to biceps, and send that to the biceps. That way if one gets damaged, we have a backup, okay? So that's what these plexuses do, is combine multiple nerve roots so we can mix them up, so we can have multiple nerve roots innervating muscles or sending nerves to muscles. Does that make sense? Okay. Okay, and we'll look at those individually. We looked at the cervical enlargement, the lumbar enlargement, the cauda equina we looked at. Okay. Once again, your book strikes with more words than are necessary. So you can cross this off, and I'm going to simplify it for you. Okay. Okay. I showed you how there's ventral rami and there's dorsal rami. The dorsal rami, guys, go to the back muscles. Done. Okay, easy peasy. Dorsal rami go to the back muscles. Ventral rami form the plexuses that we talked about and the intercostal nerves. T2 through T12 form intercostal nerves. Does anybody know what that means? Inter means what? Between. Costal means rib. It goes between each rib. Okay? The cervical, part of the upper thoracic, and the lumbosacral are going to form those plexuses that we spoke about. Okay? T12 or T2 through T12 form just intercostal. Does that make sense? I know this is a complicated thing. Okay? All right. So don't worry about the rest of this. I think this is very complicated. Okay, so then here's a picture of it. See those dorsal branches just go to the back muscles. The ventral can come between the ribs or form those plexuses that we spoke about. Okay? Yes, no? Okay. And we're almost done. I know I hit you with a lot today. So the cervical plexus. The thing that I primarily want you to know about the cervical plexus is the phrenic nerve. The primary thing that I want you to know coming off the cervical plexus is the phrenic nerve. The phrenic nerve comes from nerve rootlets C3, C4, add C5. Keeps the diaphragm alive. So if someone has major trauma to the upper cervical spine at C3, C4, C5, can they breathe effectively?
No.
No. C3, C4, C5 keeps the diaphragm alive. This is the people that have had an accident. Unfortunately, you see that they're on a ventilator, all right? And probably in a wheelchair. Branches feed the spinal accessory, then up and through the foramen magnum. Don't worry too much about that, okay? Know about the... All right, so here we are back with peripheral nervous system. We started peripheral nervous system last week. We're going to finish up today and probably start with autonomic nervous system at the end of today, okay? So, any questions about PNS? Can anybody tell me a little bit about what we talked about last week with PNS?
Cervical spines are the cranial nerves.
Cranial nerves?
Yeah.
There we go. And also
Spinal
nerves we're going to talk about in this lecture. We talked about, just listen, don't look, just listen. Because if you can picture it in your head, you know it, right? We talked about the different receptors throughout the body. What do those receptors do? They bring in sense of touch, pressure, heat, nociception. Some are encapsulated. What does that mean?
They're slower, right?
They're a little bit slower and they have a connective tissue sheath around them. Some are exposed, right? And bare. The ones that are exposed and bare deal with pain and temperature. Remember that? Nociception and thermoreceptors. Is this all ringing a bell? Right? All that information will go into the back of the cord and up to the brain. Right? Is that all ringing a bell? Okay. Okay. Now we're going to talk a little bit about the different plexuses that we'll talk about. Cervical, brachial, lumbosacral plexus. A plexus is a network of nerves, so we can mix up the nerve roots. Do you understand what I'm saying by a nerve root?
Where it comes out of the spine.
Where it comes out of this spine. Can you picture in your head that transverse view of the spinal cord? You've got the gray matter that's butterfly shaped. You've got the white around the outside, right? From the front, we have what nerve root?
Ventral.
Ventral, which is what function? Motor. In the back, we have sensory. They join together to form a mixed spinal nerve, right? At each level of the cervical, thoracic, lumbar, sacral, and coccygeal, we have nerve roots. They're numbered according to the vertebral levels. Cervical 1, we call C1, C2, C3, C4, C5, C6, C7, C8. T1 through 12. Do you understand what I'm saying? L1 through 5, then we have sacral and 1 coccygeal. Okay? We have those nerve roots come out and form this convolution or network called a plexus. So it mixes up those nerve roots. So if one is damaged, we don't lose complete motor and sensory to that specific part of the body. Okay, we can actually lose sensory, but I don't want to blow your mind. We'll actually get into that. Does that all ring a bell? Okay, so let's talk about those. Okay. There we go. Okay. This is where we left off. I know we did this one. Cervical plexus is going to be from the cervical spine. That's right. It gives us nerves that go to the head and the neck. The specific nerve that I want you to know, and there's other ones, but is the phrenic nerve. C3, C4, C5, I had you add, keeps the diaphragm alive. And the reason I teach you that is because if somebody has damage to C3, C4, or C5 in that region, they can lose the ability to do what? Breathe. And that's when they have to be put on a ventilator. Okay? Branches from the cervical plexus also feed the spinal accessory nerve. We call it the accessory nerve. It's one of our what? Cranial nerves. Okay? Good. Excuse me. Does anybody know which number it is? Very nice. Was that you? Yeah, I just heard a voice over here. Okay. So the brachial plexus, the nerve roots that will feed the brachial plexus are C5, C6. This is the range, C5 to T1. It doesn't mean C5 and T1. It means what? C5, C6, C7, C8, and T1. Okay, they come out and they form the brachial plexus. As they form it, they start as roots. Now, there's some variation. Some books you'll see it includes C4. Some books you'll see it includes T2. There's a little discrepancy with that. So if you give me anywhere in that range, that's okay. Okay? If you want to stick with what I've given you, C5 to T1. Okay? So these nerve roots come out and you could see them starting to interlace and form that brachial plexus. And the goal is to go from roots to combinations to peripheral nerves, the specific nerves such as radial and ulnar. And the way that it's organized is we start as roots. Okay? These blue represent the roots. And then we go into trunks, which are the green. The divisions and the cords are the yellow. There's actually anterior and posterior division. Excuse me, so don't blow your mind about it. Divisions and then cords. So it goes roots, trunks, divisions, cords. The mnemonic to remember that is real, tired, drink coffee. Roots, trunks, divisions, cords. It's one of the few mnemonics that I use, okay? And I would give you guys more of the things that I study, but they only make sense to me, right? My silly mnemonics, so. Okay, so real, tired, drink coffee. The brachial plexus is most anatomy students' worst nightmare. A lot of anatomy instructors, I'll be honest with you, make you study all of this, okay? All the roots, all the trunks, all the divisions, all the cords. I don't. I think it's an exercise in futility. Probably shouldn't put that on tape. People shoot me. But what I want you to understand is that a lot of damage can happen in this brachial plexus because of herniations at the cervical roots and also with the overuse of the upper arm, right? Our upper arm is very mobile and we use it to get us around, but that mobility decreases stability, which can cause more injuries in this area, okay? So brachial plexus. Does that make sense? Now, obviously, the brachial plexus is going to eventually turn into the nerves that feed the upper extremity, right? That's where it's going. Okay? Are we good with that? Now, lumbar plexus is L1 through L4. Sacral plexus is then, L5 really, but L4 to S4. I'm telling you, clinically, they roll them together. Okay? So you're not going to see somebody talk about just a lumbar plexus and then a sacral plexus. They'll be talking about lumbosacral plexus. Okay? So that's what I brought. Let me just put that up there for you. You just add an O in there. Maybe it's spell this for you. Lumbosacral plexus. So the lumbosacral plexus will be all the nerves that come from the lumbar. Okay, so L1 through L4, and then the sacral portion will pick up the rest through S4. So we have L1, L2, L3, L4, L5, right? S1, S2, S3, S4. Okay, it's going to be all the nerve roots that will feed into the lumbosacral plexus. Okay, lumbosacral plexus. That will give us all of the nerves that will go down into our peripheral and lower extremity. Okay, so brachial arm makes sense. Lumbosacral will be to the lower limb and pelvic basin. Okay, does that make sense? And this one tends to be one that's damaged a lot from herniated discs. When people have pain down the lower extremity, it generally is from the lumbar spine. Usually 3, 4, 4, 5, somewhere in there. Okay. We're going to go over, I don't think I go over them in lecture, we do them in lab, the peripheral nerves. Down the arms and legs. Those are important to know, but I do it in lab so we can do it hands-on. Okay? Just as a sidebar. Okay, so does this all make sense? So if it's coming from that nerve root, is it going to be sensory motor or both? All these, the cervical, lumbar, sacral plexus, you're correct. Go ahead and say it.
Both.
Yeah, it's both, right? Because it's that mixed spinal nerve that's leading into the plexus, that's creating it, so we're getting mixed spinal nerves going out there. Are you with me? So then when we get out to the periphery and we learn about those peripheral nerves in lab, those are mixed spinal nerves. So they'll have sensory motor in both, yeah? Okay. That's what most nerves are. There are some exceptions. When we talked about the cranial nerves, we did sensory, motor, or both, right? Some of those are sensory, some are motor, some are both. But the majority of the nerves going to the body will be mixed. Okay? Now, here's another exception. Oh, I'm not on the right screen. Excuse me. Okay? Innervation of the skin. So we have a little, if you could picture back to the spinal cord, okay? From each of those spinal nerves that come out, there's actually a branch that is sensory. And it goes to the dermis. Now, where is the dermis? It's the what? She's like, wait a minute, you're going off road. That's not in this chapter, right?
The dermis is the top layer of skin, right?
It's the middle layer of the skin.
The dermis.
So if you could take a second and just think about those layers of skin. We've got the epithelium on the top, all the cells. That middle layer that I said where everything's going on, right? That's where the nerves are. So what I just did, I felt it. I felt it because of the nerves in my dermis. Are you with me? Each one of your cervical, thoracic, lumbar, and sacral, and coccygeal nerve roots actually have just a sensory branch that go to a very specific area of the skin. And it's pretty typical and common for us to have them all in the same area. Those are called dermatomes because it's the dermis that senses it. Tome, I think, is a region or an area. Are you with me? Does that make sense? So if you think somebody has damage to one of their cervical nerve roots, I'm going to show you how you test it, right? Would you test it with motor? No, you're testing what?
Sensory.
Sensory. Does this all make sense? People have trouble with dermatomes, so I want to make sure it makes sense. Okay, so all the spinal nerves except for C1 participate in these dermatomes. Okay, most of them overlap. So if you check somebody's skin and they're like, I don't feel as well on one side as I do the other, do you immediately put them in surgery? No, you gotta send them for tests, right? X-ray, MRI, CAT scan, whatever it may be. Okay, MRI or CAT scans would be your best choice, right? Okay, so learning about and testing dermatomes are a general, too soon for a break. I don't know why I put it in the middle of that anyway. Okay, are a general way that you can test patients if you think they have nerve damage somewhere. Okay, and of course the most common way or the common reason we would test would be for what do you think? What do most of us have in our spines? Actually, about 80%, I believe I read from the research, people have these in our discs. No? Herniated disc. 80% of the population has a herniation. It just doesn't push on the nerves in all cases, okay? So, checking dermatomes is a quick and easy way we can test for a what? Herniation.
Yeah.
Okay, it's your bread and butter if you're going to go into an orthopedic practice, ortho-neuro practice. Okay, all right, does that make sense? So looking at this, and we're going to go over this in lab. We're going to go over the arms and the legs. Those are the ones that tend to manifest the most frequently because these are where the discs get damaged the most frequently. And we tend to damage in the mid-ish cervical spine and the lower lumbar spine because cervical spine is really mobile, right? And also unstable. I mean, you've got this head that's about the weight of a bowling ball, right? If you get it whipped around in a car accident, you can damage the discs. Why would we be more prone to damage the lumbar discs? What'd you say? Lifting, there's just more weight, right? More weight goes through the lumbar spine than we have in the rest of the spine. Okay, good. So we tend to test upper extremity and lower extremity. We've got on the side of the arm here C5, and that correlates to what again?
Oh, that's breathing, right?
Oh no, not what its function is. It just correlates to cervical, the fifth cervical,
Oh,
right?
yeah.
Nerve root, right? I was trying to keep it simple. Okay, C6 will be the thumb, that's going to be cervical nerve root 6. Do you understand what I'm saying now? Okay, right. C7, I usually use the middle finger. 8, I use the pinky. And then T1, I use the inside of the arm. So would you test it on one side or both sides? Both sides, right? Because if somebody has a herniation, it's usually one side, and you're comparing side to side. We're actually going to do this in lab. Is this making sense?
Why it's only on one side?
Herniations, because the way that the disc is structured, it's like a jelly donut. So if you keep squeezing a jelly donut, it's not going to pop out two sides generally, right? It usually will go out the weakest point of the outside of the disc, just like you would with the outside of a donut. Does that make sense? Yeah. Okay. So in the lower extremity, you can see just about the kneecap is 4. The lateral leg is L5, which correlates to what again? Lumbar nerve root 5, just making sure everybody's getting it. And the lateral pinky toe, which would be S1, which would be first sacral nerve root, right? Testing both sides. Does that make sense? Okay.
Very confusing.
We're gonna go over it in lab again, okay? So with dermatomes, they are a superficial nerve root from every one of those cervical, thoracic, lumbar, sacral, and coccygeal nerve roots. Goes to the dermis, usually in a very repetitive manner from person to person. So you can go through and screen people and make sure that the sensation's okay. If the sensation's not okay, generally there's a herniation that's pushing on the nerve root that isn't sensing as well as the other side. Does that help a little bit? Okay. Okay, so dermatomes. All right. So, sensory nerves. So you can, obviously, and we've mostly talked about somatic, and somatic once again means what? Body, right? You also have sensory nerves to your organs. And that is getting into the autonomic part of the nervous system, or automatic, I call it, okay? So generally, what happens with those nerves is we don't feel them unless we have what? Some sort of damage or dysfunction. Do you normally feel your heartbeat? Unless it's racing. Do you feel abdominal pain? Abdominal dysfunction, abdominal organs? No, not unless there's pain or dysfunction. And part of the reason for that is there needs the sensory for the viscera or the organs deals with pressure on the chest and the abdominal wall. So if your heart starts to race, you'll actually sense it on those sensory nerves on the chest wall. If you have appendicitis, it swells up to the point where it pushes on the abdominal wall and it triggers those sensory nerves. Does that make sense? That's why you normally don't feel it. Okay? So, just as a little sidebar. Okay, so we have skeletal muscles, they have a motor unit, they have a sensory unit, we have a nerve going to the muscle cell, and acetylcholine is the neurotransmitter. Okay, make note of that. Some people missed that from not last lecture, would have been 2 or 3 lectures ago. Now, we have in the motor compartment a voluntary and an involuntary component. Voluntary means, and I'm thinking about moving around the room, so I do. Involuntary is a reflex, and a reflex is put in place to do what for us? What do reflexes do? Yeah, they help to, sorry, my nose is itching all of a sudden, protect us in some sort of manner, okay? The reflexes are put into place to protect us. They actually will respond at the spinal cord. Okay, why would we want them to respond at the spinal cord? faster, right? It's quicker, okay? So there's what's called a reflex arc that brings that damaging nociception into the back of the cord, and then there's immediate motor response, okay? And there are specific reflexes. We're gonna talk about, I believe, 2 of them. Are there more? Sure, but this is what we're gonna talk about, okay? So a spinal reflex is this one, okay? These are going to be stretch reflexes that are sensed in the spinal cord and immediately cause that muscle to contract. I'll go back to those notes in just a second, but I want to explain to you first. Well, actually, I could go back to them now that you see the picture. Okay, so sensory comes in to the back of the cord, and then immediately there's a second nerve called an interneuron, which sends the signal directly to the motor nerve to cause a response. So it's 3 nerves: sensory, interneuron, and the cord motor neuron coming out of the front. So that way it's quick and efficient. I'm redoing these notes as a sidebar. These are a little disorganized, and I apologize. I got them straight out of the book. I need to redo them. But anyway, jumping down to here, so you have that reflex arc, but you do also send signals to the brain, right? You'll get sensory information saying, whoa, what happened there, right? Okay, so your brain will sense it, but that one reflex arc will be quick and efficient, so we can immediately respond, okay? Examples of it are, so this is kind of lumped in together, okay? Flexor crossed extensor reflex. It's 2 reflexes, but they always go together. So let me show it to you and it'll make sense. In college, I went to a party and the drinks were on the stove. Somebody had put the stove on. Being slightly intoxicated, I thought that the drinks were stuck to the stove. So what did I do? Put my hand on the stove to pull the drinks off, right? I put the drinks down or let go of them, and I did this, right? Flexor crossed extensor reflex. The flexor portion does what? Get you away, and I'm over exaggerating, of course, but I want you to see. You pull away from whatever is damaging you, but you don't want to what? Fall, right? So you extend your other arm, okay? Flexor crossed extensor reflex will pull you away from a damaging stimulus and hold your hand out to make sure you don't fall, okay? So this is one reflex. Does that make sense? Stretch reflexes. There are stretch reflexes in the upper and the lower extremity. There's also abdominal ones. We're just going to go over patellar. Okay, and it's called patellar because it's obviously where your patellar ligament is, right? And we're all familiar with that, right? Okay, that's actually my reflex. I'm very reflexive with that. So what is happening is you're stretching this, let's just say tendon, it's really a ligament, but let's say tendon. That tendon connects to a what?
Bone. Or muscle.
To a muscle, right? So the muscle, and the muscle is attached to the bone, and the tendon attaches to the bone. Okay, so the muscle is here, it attaches to this tendon. Are you with me? When you do that patellar reflex, what's happening is your body thinks this muscle is getting stretched too much. And if you stretch it, lengthened too much, okay? Yeah, stretch too much. If you stretch it too much, you can actually rip muscles right off the bone. Okay, have you ever seen like football players, they rip their Achilles tendon? That's what's happening. It's getting ripped right off the bone. You can do that with your biceps too. You can rip it right off the bone. So this muscle's like, wait, too long, you're stretching me too long, so it's gonna do what? Contract. So it shortens the muscle so it protects it from being ripped off the bone. Are you with me? So when you contract this one, you're also going to relax this one, right? Because they work as pulleys. And if you were to contract them both at the same time, you wouldn't move. So this one contracts while your hamstrings relax. So that way you're bringing that muscle out of being overstretched. Does that make sense? And like I said, there's other stretch reflexes, so just go over that one. We'll go over some more in lab. Okay, so quick stretch causes the muscle to contract, it's trying to protect itself. The antagonistic, which means the opposite muscle is turned off. Okay. Now, we test these clinically. Now that you know a little bit about the peripheral nervous system, you've probably gone in and had people check your reflexes. What are they checking? The sensitivity of your reflex. Would you do it on one side and not the other?
Both.
No, you would do both and compare them. So what are some things that could go wrong with these stretch reflexes? We've talked about one ad nauseum at this point. You could have a herniated disc. If it's compressing one nerve root, the reflex won't be as strong as the other one. What if you have damage in your spinal cord, or you have MS that's affecting the motor component of your central nervous system? I'll buy you a candy bar on break if you answer this for me. You have somebody who has MS. They have plaquing in their central nervous system. You go to take their patellar reflex. What do you think might happen?
It's transmitting the cycle.
You win. Sorry. Oliver got it. You could have spasticity or hyperreflexia. So you also need to know about what normal is. I am almost hyperreflexive. I always have been. So if you take my reflex, that's my reflex. But if you have somebody who does that, right, they might have central nervous system damage. So not only might you have a decreased reflex, there's a scale, I think I might go over it in the lab notes. I'm not sure. You could have hyperreflexia, which would be upper motor neuron versus what? Lower motor neuron, right? Okay, does that make sense? So if you have a herniation, it's gonna damage that lower motor nerve, right? If you have MS, stroke, tumor, it would damage brain and spinal cord. Did I just blow your mind? Does everybody understand that? All right, if you don't, come see me. All right. Just a little thing to keep in mind is out in the periphery, we also have sympathetic and parasympathetic nervous system. We have a complete lecture unto itself for that, but I just included a little introduction in this part of peripheral nervous system for you, okay? So autonomic nervous system, I always think of it as being automatic because it's gonna control all those automatic functions in your body. Breathing, heart rate, yes, you have some voluntary control over breathing, but it's primarily involuntary, digestion, etc. Anything that you could think of that's automatic. It's broken down into sympathetic and parasympathetic. We're going to look at those two divisions and what they do. Okay. Okay. Once again, jumping ahead to just two sides. So the thing to keep in mind is sympathetic is fight or flight. That's a part of the division that it comes from the development of our hindbrain years and years ago. I shouldn't say really hindbrain because it's the whole brain, but from when we were cavemen, and it decided whether we would stay and fight the bear or run away. It gets the body ready for either one of those physiological functions. Can you stay in that sympathetic facilitation all the time? Absolutely not. It depletes your stores of glucose. It releases cortisol, which is good for short bursts of energy, but long-term release of cortisol can actually eat away at your tissues. And it doesn't allow your body to rest and regenerate itself. So what part of the sympathetic, or what part of the autonomic nervous system kicks in at that point? Parasympathetic. So it's a balance between the two. You can't be a sloth all day. Don't you love sloths? My daughter loves sloths. They're so cute. But you can't do that all day, right? And you can't be stressed out all the time because that's not good for your body either. So the balance of the you love sloths, don't you? One of you over there?
No, we're talking about you can't be stressed all the time.
You can't be stressed all the time. I'm gonna sneeze. I mean, you can, is it good for you? It's not. So it's this balance between them, okay? That is important to get to. So sympathetic and parasympathetic. So then if we backtrack one more slide, okay? So sympathetic fight or flight, it is called thoracolumbar because it comes out at the levels of the thoracic vertebra, between each one of the thoracic vertebra and just a little bit of the lumbar, thoracolumbar. So the nerves for sympathetic come from thoracolumbar region. And I'll show you how it's organized. Parasympathetic, which is our relaxed, is craniosacral. So that comes from cranial nerves and sacral nerves. We'll go over the specifics in the next lecture. So sympathetic is what? Comes out of the thoracolumbar regions. Parasympathetic comes from cranial nerves and sacral nerves. Does that make sense? Okay, we'll get into the specifics of where in a little bit. Sympathetic goes to all organs. I think one of the main things to remember, well, it's critical for many things. It goes to all of our blood vessels. So when you get nervous and you stimulate those nerves, it'll contract all your blood vessels. Now, why is that important to understand? What would that do to our blood pressure? Yeah. Just like a hose, when you cover the end of it, when you're decreasing the diameter of blood vessels, you will create an increase in blood pressure. That's why high blood pressure can be a byproduct of stress. And then if you calm that sympathetic nervous system, it'll decrease the firing of it to blood vessels and they'll open up and relax. Okay? So sympathetic goes to all organs. Parasympathetic has less nerves, doesn't go to all the organs. For example, the kidneys just have sympathetic. Adrenal glands just have sympathetic. Okay. All right. Now, there's different neurotransmitters at the end. This is actually a little confusing, and we'll get into where it's confusing in the future. So when your sympathetic nerve goes to whatever organ it's innervating or going to, so the sympathetic nerves that go to the heart, the sympathetic nerves that go to the blood vessels, whatever it may be, that neurotransmitter that goes from the nerve to the receptor. Can you picture, remember how we talked about the axon terminal, right? And the synapse, and then whatever that receptor is. We looked at a skeletal muscle, but that's true of anywhere that nerves go to. Organs, glands, heart, blood vessels. Wherever these sympathetic nerves go to, they release norepinephrine. Okay? The neurotransmitter for sympathetic nerves, so wherever those sympathetic nerves are, they dump off norepinephrine. Okay? And norepinephrine's actions tend to be to increase something, increase heart rate, increase blood pressure, etc. Okay? It's a stimulatory neurotransmitter.
So this is in parasympathetic?
No, sympathetic.
Oh, yeah.
Yeah, sympathetic. Parasympathetic releases acetylcholine. Okay? Acetylcholine can be stimulating, it can be relaxing. It depends on what it's going to. We saw acetylcholine in the muscular system, right? In the voluntary muscles, it stimulates voluntary muscles. In the parasympathetic nervous system, acetylcholine could actually slow things down. It depends on what it's going to, okay? But wherever those parasympathetic nerves go to, the neurotransmitter that will go to whatever receptor it is will be acetylcholine. Okay, does that make sense? All right. Okay, oh, we got through this one. So I need to go back one. Okay? So if I'm looking at these nerves that come out of the thoracic spine and the top of the lumbar, are they sympathetic or parasympathetic? Thoracolumbar. Sympathetic. All of these nerves that are coming out of the spinal cord in the thoracic and upper lumbar are sympathetic. All of the nerves that come from cranial and sacral are what? Parasympathetic. Is everybody with me? Okay, because it gets harder. I'm going to explain a difficult concept. I want you to not make it super difficult. I want you to listen to me first, and then you can make notes after. Okay, are you listening? Don't write. Listen. Because this is not difficult, and people make it difficult, and you need to know the gist of this. Each one of the nerves that come out and go to the organ actually have two nerves. So if we look at all these nerves that come out of the spine and sympathetic, here's one nerve, it goes to a ganglion, right, which is where the cell body is. At that point, we have a second nerve that goes to the organ. That's it. That's all you need to know. Parasympathetic also has two nerves. Are you with me? It'll have a cranial nerve, it'll come out to a ganglion, and then to the organ itself. They both have two nerves. Are you with me? And we'll get into the specifics of why you need to know that in a little bit. They each have two nerves. Sympathetic ganglia are right next to the spinal column. Why? Because that's how they're structured. Sympathetic ganglia are right next to the spinal column. The reason that's important is because if somebody has some sort of surgery in that region, they can actually have damage to that ganglia, which would decrease whatever that sympathetic response is coming out of it. Does that make sense? Okay, so I told you I'll explain it again so you can write it if you want. Both parasympathetic and sympathetic nerves, or pathways I should say, are going to have two nerves going out to the organ or muscle that they feed. That sympathetic one, the first one is really short, and then there's a ganglia right next to the spine. The second one would be long, going out to the organ. So sympathetic has two nerves. The first one's short. It goes to the ganglia right next to the spine. The second one would be long. Do you need me to repeat that? Sympathetic, do you need me to repeat it? Or is that a no? Yes. Sympathetic has two nerves. The first one is short, and it goes to ganglia right next to the spine. The second one would then be long, going out to the organ.
Goes to ganglia and then to organs.
Goes to the ganglia and then to the organ. So the first nerve is going to the ganglia, right? Or the first axon, I should say, will go to the ganglia, talk to that cell body and that ganglia, and send the signal out by the second nerve. Okay. Anybody need me to repeat that? In parasympathetic, which comes from the cranial nerves and the sacral nerves, there's two nerves as well. The first one is long because the ganglia and parasympathetic are close to the organ. So in parasympathetic, it has two nerves. The first one is long, or the first axon is long. the ganglia are close to the organ. So the second axon is short and parasympathetic. Okay, does that make sense? So two nerves in both. Sympathetic short first, long second, parasympathetic long first, short second. Woof, everybody's like, woof. Okay, and this is actually in the notes in autonomic nervous system. We'll go over that again. All right. Okay, so innervation of skeletal muscle. We've actually gone over this, so I'm going to go over it quickly. If there's something you don't understand, stop me. Talking about the nerve that goes to the muscle itself. So we've got that axon terminal, the synaptic cleft, and then the muscle receptors. Acetylcholine is released. We're talking about skeletal muscle. And then it's broken down by acetylcholinesterase. Don't worry about basilamia. Acetylcholinesterase, anytime you have ASE as a suffix or an ending. Suffix is an ending, right? Yeah, okay. For a second there, I was like, wait a minute. That means an enzyme. Acetylcholinesterase will break down acetylcholine. Because if you kept releasing the acetylcholine and attaching it to the skeletal muscle, what would happen? We keep firing. And interestingly enough, we need energy to break apart acetylcholine. So when you die, you go into what? Rigor mortis. Because acetylcholine stays in the synaptic cleft, we don't have energy to break it down. It keeps stimulating the skeletal muscles and people move into rigor mortis. As our muscle fibers start to degenerate, then the muscles will start to relax. Not relax, but let loose. Okay? So that's what happens with that. Weird and morbid facts. I had such a brilliant idea the other day. I'm like, I could do that. I could do a TV show with weird and morbid facts. There's already like 2 or 3. I'm like, darn it. Darn it. I could be famous. All right. So innervation of viscera, which just means glands and muscle or organs. Okay, viscera means organs. It's organized. I would not talk to you about varicosities. It's a network, almost like a fishnet kind of thing around the organ, as opposed to the axon terminal and the receptor like we see in skeletal muscle. But we do need to know that glands and organs will have acetylcholine or norepinephrine, right? Norepinephrine is released by what part of the autonomic nervous system? Sympathetic. Acetylcholine is released by parasympathetic, okay? Reflexes, we went through this, so we've got those intrinsic reflexes to protect us, and then we have learned ones, such as driving. Driving actually becomes a reflex after a while. You don't have to think about it, you just do it, right? So, or people who play piano really well, they don't sit and think about every note they're doing, it almost becomes reflexive, okay? So spinal cord reflexes, we looked at that. That'll happen in the spinal cord. That's the integration center. We'll have that skeletal muscle response. It's clinically important to assess this, to check out the nervous system. We completely went over this already, right? If we have a decrease in that reflex, it'll be damage to the peripheral nerve. If we have an increase in the reflex compared to the opposite side, it could be something in the brain or the spinal cord. Here's the picture. I put this in case it helps you. It confuses me, frankly, but it's a picture of that reflex arc with that stretch reflex. And it shows all those steps, but it's pretty much what we spoke about. If you're a visual person, it may help you. I find it a bit confusing, but I throw it in there to give you an option to review that. As long as you understand what we spoke about, you're good to go. Flexor and cross-extensor reflex, we talked about this as well, okay? So this is a painful stimulus. It's that automatic withdrawal from that threatened body part or with the threatened body part. Ipsilateral and polysynaptic. So they, ipsilateral, I guess we should talk about that. Ipsy means same-sided. So the ipsilateral response will be on the side of the stimulus, okay? Contra means opposite. Contralateral means your opposite arm. So you'll have an ipsilateral flexion and a contralateral extension, okay? Polysynaptic just means multiple synapses. Okay, so ipsilateral means same-sided, contralateral means opposite-sided. Those are two words that you should be familiar with, okay? Okay, here's that cross extensor portion of it. I just have it broken down, quarters together. You'll have that contralateral extension. The withdrawn or flexed part will be the ipsilateral side. And we went through all this. Are there any questions on it? Okay. Now, superficial reflexes are a series of tests. Do I give you an example of these? I think I do Babinski's, right? Yes. Okay. So superficial reflexes are a series of tests that orthopedists or neurologists or even primary carers could do. I used to do this as a chiropractor. If you think there's some type of upper motor neuron damage. And the one most frequently taught and also done is the plantar reflex on the bottom of the foot. Have most of you done this in lab already? Yeah, I know that. Did we do it in our lab?
Yeah, you showed us a video, I'm pretty sure.
Yes, we did go over it, that's right. So people will usually do the plantar reflex, which is the bottom of the foot. I'll actually show you a video. You stroke the bottom of the foot in a very particular way to see how people respond to it. Can anyone guess why you would do the feet first?
The most furthest away from the body.
Yeah, it's the most furthest away from the brain. So if you're having a neurological issue in the central nervous system, you can do this plantar reflex, which would be the furthest from the brain. We could see if there's some, I'll give you some candy too, don't worry about it. See if there's some kind of response as well, okay? With these superficial reflexes, do you think it would be a decreased response or an increased response? With these superficial reflexes, if we're, I'll even add a little some, if we're testing central nervous system, is it going to be a decreased response or an increased response? It's usually going to be an increased response. There's one called a glabellar reflex, okay? So it's right here. I could tap all day, no response. If you think somebody's had a stroke and you do this, they'll go like that. Is that normal? No, obviously. If you tap someone there and they do that response, that'll be pretty obvious. With upper motor neuron lesion or damage, you will have an increase in these superficial responses, okay? And they look really abnormal. Like they're really, like even if you were to do it and not be a clinician, you're like, oh, that's not good. You know what I mean, kind of thing. So the one that we talk about with these superficial reflexes, so once again, this will be upper motor neuron pathway, which is going to be basically brain and spinal cord, yeah? Okay. The test that I'm going to go over is plantar reflex. Oh, let me see if this is still a viable link. Some of these are not viable anymore, but I can bring it up pretty quickly. Okay. No, maybe.
Now I'm going to do the plantar reflex. Now just hold still, try not to pull back, just relax as much as you can. I'm going to go down the lateral aspect of the foot and across the ball of the foot.
That's a normal response, kind of like, get away from me, what are you doing?
Side.
Right, get off my feet.
Same thing,
Okay.
just relax. There you go. Very good.
Okay, that's the normal response. Oh, let me see. Oh no, this girl is great by the, well, I should say this woman. Registered nurse RN if you're going to.
You want to succeed in med school, but reading textbooks usually puts you asleep?
Really great overall reviews of nursing things. You want to definitely get connected with her. Now, if somebody has damage to brain or spinal cord and you do Babinski's, the toes come up and out like that. Now I love putting this picture up because it's a little baby and they're so stinking cute, and I used to do this to my kids all the time. Now wait a minute, Dr. Deshava, you just said this was an abnormal response. And I already said this in my lab. Why is it not abnormal in a child?
It's not fully developed yet?
Not fully developed and their nerves are not fully myelinated. So they will have that response until just about 1 year old. But if you did that in a healthy adult and it came up, obviously there's some, well, not healthy, right? There's going to be some sort of damage to brain or spinal cord, okay? So superficial reflex. So plantar reflex is the test, okay? And the normal response to push the toes down. If the toes come up and out, it's known as Babinski's sign. So that's an abnormal finding. Okay, so dorsiflexion of the hallux, that means the big toe comes up and the rest of the toes fan out. Okay. In adults, it indicates corticospinal or motor cortex damage, remember, as brain and spinal cord. Okay, brain and spinal cord. Right? Does that make sense? And there's other superficial reflexes, obviously. This is just an example of one. Okay? Abdominal reflexes cause contraction of abdominal muscles and movement of the umbilicus or belly button in response to the stroking of the skin. It varies in intensity from one person to another. It's absent when corticospinal tracts, which just means brain to spinal cord, which will be that motor function. Okay? Normally, and I'll show you the video. Hopefully this link is still viable too.
T5 to T12, we're going to stroke the skin towards the umbilicus and watch for a contraction of the muscles. In the epigastric area, I'm going to stroke towards the umbilicus, watch it contract. That's from T5 to T7. T7 to T9, the upper right quadrant, scratch towards the umbilicus, watch it contract.
You don't need to know the specific
Just
levels.
lateral to the umbilicus is approximately T9 to T11. And then from the inguinal region up towards the umbilicus, watch it contract, is approximately T10 to T12.
Okay? If you were to perform that on someone and there was no response, that would mean there's some sort of damage to the thoracic nerve roots. Okay? So, all right, does it make sense? Good. Oh, all right, there we go. So that, my friends, is the end of peripheral nervous system, other than the named peripheral nerves, which we will do in lab. Do you have any questions about any of that?
Will we see those reflexes, for example, if belly is distended?
Oh, there might be a change in the reflexes if there's bowel distension, sure. Because it'll be painful for them also as well, so they'll be a little guarded. So, and also the inflammation, I would think, could go back to the thoracic spine. I'm guessing, I've never seen it clinically, because that's not something I would deal with, obviously, as a chiropractor, but I would guess it probably would be. Good. Any other questions?